Good morning, dear colleagues. Welcome to this ECOG seminar. My name is Daniel Weghuber. I am the current president of the European Childhood Obesity Group. I am a professor of pediatrics, specialized in pediatric gastroenterology, hepatology, and nutrition, and with a clear focus on childhood obesity as my research topic. So it is great to have you here. Most of you will be very well familiar with ECOG, and you will know that we were actually planning on celebrating ECOG's 30th anniversary in Budapest this fall. But instead, we have postponed this to go there next year. We can't wait. And we have decided to launch a webinar series instead. We had a fantastic kickoff webinar on October 20th with the WHO as our guest. We had fantastic feedback from this. Today's our second webinar, and I can tell you it will be a very good one as well. Translating research into clinical practice is ECOG's motto. Ever since, this has been what ECOG has been dedicated to do, to translate what we know from research into our daily practice. And one of the main issues in treating children and adolescents and their families who are obese is to make sure that they actually get in contact with us and stay in contact and adhere to treatment. Adherence to treatment of obesity and associated comorbidities in youth is our topic for today. And I would like to invite you to sit back, relax, and there are a few practical informations that I would share with you. Number one, the webinar is recorded and will be made available together with the slides on our website. Very important, there is a Q&A tool that we ask you to use for questions. There will be brief Q&A sessions after sessions and at the very end. Don't use the chat function for that. Use the Q&A tool for this. If you want to have answers that remain answered, please do not hesitate and contact us after the webinar as well. This webinar is in partnership with the Austrian Society of Public Health and with the support of Novo Nordisk. So it is now time to look at the agenda. We have three renowned speakers who really know what they're talking about. Two of them are actually from Canada, so it is a Canadian-European collaboration today. And it is my great pleasure to welcoming our first speaker, Michael Vallis from Dalhousie University, Canada. Dr. Vallis is a registered health psychologist based in Halifax, Canada. He's a health behavior change consultant and associate professor in family medicine at Dalhousie University. His main area of expertise is adult health psychology with an emphasis on obesity, diabetes, cardiovascular risk, and gastroenterology. He spends most of his time training healthcare providers, just as us, in behavior change for chronic disease management. He regularly supervises clinical and academic students at Dalhousie and is active in research on motivation, behavioral change, and adaptation to chronic disease. He was recently awarded a Queen's Diamond Jubilee Medal by the Government of Canada on the recommendation of the Canadian Diabetes Association. So it is your floor. Michael, thank you for being with us.
Thank you very much. I'm just going to share my slide, share my screen rather. Okay, I'm hoping that people, can you confirm that you can see my screen? Okay, thank you. So thank you, everybody. I welcome this opportunity to discuss the issue of adherence with you. As you reflect on this presentation, I'd like you to just keep in mind, how do the outcomes that we're trying to achieve with our patients, families, children actually come about? And think about it, did they come about by what we do inside the clinic? And in some contexts, yes, this is exactly what is the mechanism of change. And this is the traditional expert model. But many, and if not most of the outcomes that we're trying to achieve aren't determined by what we do inside the clinic, but what the patient and family choose to do when they leave the clinic. And so that's really where the behavior counseling component comes in. And so I'd like to chat with you a bit about that. These are my disclosures and just a map of where I live in the country, the far east of Canada, a beautiful city called Halifax. And so the best way, I think, to put the context around this is to maybe discuss some of the potential challenges that we encounter in a treatment program. So just imagine, that you're working with this individual and she's 16 years old, complaining of really treatment fatigue. She's been in the program a bit and she's kind of getting tired of being in the program. She's distressed and tearful over not achieving the weight loss that she had expected. She'd sort of begun this program with high expectations. And she's become intrigued by a well-known celebrity claiming a quick and easy way to get the body that you've always wanted. And so here's a common situation where we see that the individual's kind of drifting away. There's other expectations or hopes that get elicited by things that happen outside of the trial. Similarly, here's another adolescent who is basically in the treatment program because the family wants him there. So here's a 17-year-old high school student objecting to the frequency of clinic visit. It interferes with his rugby and other activities. He doesn't really see his size as a major problem. And he agreed to the treatment really out of pressure from his mom. And now he says, I didn't realize just how annoying this is. And so I framed this up for you as a way of understanding what I'd like to call pushback, which is we engage with people, we engage with families in that goes pretty well at the beginning, but pretty much inevitably there reaches a point where the individual is becoming quote unquote resistant. This is why we commonly hear the word non-compliant, and it's the pushback that becomes really important. And this is the key to adherence, is actually managing that pushback. And so I'd like to launch a quick poll now and just ask you, you'll see coming up on your screen the question. And the question is really these scenarios, when we think about those two scenarios I presented, they're very common. And what do you think the most common emotion is that is elicited from the healthcare team? So when we encounter these kinds of pushbacks, do we feel satisfied, frustrated, excited, or hopeless? What are the dominant reactions, would you think? Take a moment and complete this, and then we'll just get a quick sense. We'll be able to get feedback from this one. So it'll take about 30, 40 seconds for people to complete. Once we get the majority of responses, then we'll see the results. Frustration, absolutely. Thank you. That was the whole purpose of that. 72% of us can recognize this. And so this is one of the most important takeaways of my presentation today. Is there anything that I can say to you that will help you really address adherence challenges? So pushback, resistance, a non-compliance, I'd like us to consider to maybe abandon those words and think about it as adherence challenges. And how do we shift from frustration to engagement? And there's 3 points to my presentation, really. One is that I'd like you to view retention challenges as normal, healthy, and expected. So when you encounter them, the frustration is based on the fact that you hoped they weren't there. And then when they're there, you think, oh no, not again. And so I'd like you to leave thinking, no, they're going to be there, because that's in fact normal. That's normal behavior because, and I'll try to demonstrate this to you, that it really reflects what we call ambivalence. And this is based on how the brain actually works. And so what ends up happening is that we start a pathway and then we think, oh, what about some of the alternatives? So think of that 16-year-old who hears about, oh, there's a better, quicker, instant solution to your problem. And so they start to experience the reasons not to change. Or we see people falling back into patterns of inaction. That's actually really, really common. If you've ever tried to change your own behavior, a cold, miss the gym for 4 or 5 days, and then don't ever go back to it. This is really, really common. We want to appreciate the unique challenges of adolescence in this developmental spectrum, and also to appreciate the unique challenges of obesity management, which I think have some particularly important adherence challenges associated with them. So I'd like you to reflect, if you can understand behavior, you can help change behavior. So all too often, I think that providers think, here's a particular behavioral challenge, or I would recommend that my patient engage in behavior X. And we try to jump right into, here's how you change this behavior. This point is to suggest to you that first understand what's going on, what's driving the behavior, before you start to strategize around what to do about it. And the primary reason for that is on this slide here. And so this is the slide of behavioral choices. What do we know about the choices that people make? And we know that we all go through life kind of being pulled between what we want and what we know is in our best interest. So you know you should incorporate physical activity into your day, but the only way that you can do that is by getting up early and making it happen before you start your day. But you don't really want to get up early because you're tired and sleeping is such an enjoyable experience. And you will go through your whole life being pulled between this. And it reflects the fact that there are 2 behavioral control systems in the brain, and you see them here. There's the limbic system, and this is the emotional area of the brain, instinctive emotional function. This is the wanting part of the brain. And then the frontal lobes, the executive functions, the logical, problem solving, delay of gratification, distress tolerance space, necessary for change. And so what ends up happening really is that we start out okay, that because you're engaged, your families come in, they're engaged in the program, so they want to be there. This is a conscious decision they make. They start down the journey, and then they start to experience the wanting components, and they miss some of their old patterns, or they're finding it challenging to continue with these. This is absolutely normal. And what I would like you to understand is that this is where communication comes in. The patient-provider communication, in a way, is very essential at overcoming this limbic system resistance. And so I think that's really important for you, allowing for the kind of recognition of this. It's useful to think about that understanding behavior. What do we know about behavior? Quite simple. 3 points I'd just like to make to you. 1, healthy behavior, what we're asking people to do is actually, in the current context of our societies, kind of abnormal, because the human brain was developed such that we focused on the following: pleasure, convenience, and immediate consequences. And we recognize that health behaviors now require us really to push against those 3 principles. And that's why your supportive relationship with your children and family is so helpful. Also, keep in mind the most common coping response is avoidance. So expect avoidance so that you can roll with it. Expect it so that you can do something about it. I like to think about avoidance as plan A. So the patient just doesn't want to deal with it. They just want to make it go away. And you think, well, great, think about that as plan A, and then ask permission to discuss plan B, because that's where change can come. People don't follow their own recommendations. They follow their own beliefs. And so it's important for us to then sort of understand their beliefs, start to understand what are they thinking about, and so that we can use that as a framework for going forward. And that's important because if you just kind of keep focusing on the recommendations, but this is what the evidence says, this is what is in the best interest, then if the patient isn't ready, what can happen is the two things we call psychological reactance, which is that sort of pushing back. We see this all over the world now with wearing masks and COVID. Many people are thinking, don't tell me what to do, and then they want to resist. This is called psychological reactance, and it's based on the perception of being controlled. Or they'll try your methods, and because they're not really committed to it, they'll try and fail, and this develops something called learned helplessness. So again, this is where the communication skills become so very important for us. And then the final point is one that we've just demonstrated, which is we know that this battle between the frontal lobes and the limbic system is really an unfair struggle because the emotions tend to dominate. It's also important to understand developmental neurobiology, and this is just showing to you the development of the frontal lobes over the lifespan from age 5 to age 20. And you can see that this frontal lobes, which is so necessary for controlling behavior, is really not well developed. And that's why you experience on a daily basis this sort of developmental spectrum, right? At what point does the child develop sufficient executive functions that you can interact directly with the child? To what extent do the family maintain control over the behaviors? And these are the challenges that you face on a constant basis. And knowing, of course, that the adolescent brain tends to be very focused. Adolescence is quite important, and I just want to normalize what is the job of adolescence. And there's two kind of semi-inconsistent tasks if you're an adolescent. The psychological tasks of adolescents are to be as different from authority figures as possible. This is to establish autonomy on my own person. Why? Because you tell me what to do and I do the opposite. And I want to be as much like my friends as possible. So you struggle with this on a constant basis in your families. And again, knowing that it's actually a normal development, then the challenge you see is to have the tasks of obesity management not get tied up in these autonomy struggles. And that's the kind of nuancing of behavior change counseling. And again, just to emphasize, the tendency to act the opposite to what you're asked to do is really called psychological reactance, and it's based on a need to be independent, a need to be controlled. This is very much based, don't worry about the complexity of this slide, very much based on what's called the circumplex model of personality, in which we sort of have these sort of dominance and affiliation as our basic kind of character. But what happens is when we ask the question, how do people stay connected? We know that if one person sort of dominates a relationship, the only way to maintain connection is to be submissive. That's why we see in much medical exchange that the patients don't tell doctors what's really going on because they fear the judgment. So it's really where we think this non-controlling curiosity stance becomes so important. And that's why in the face of barriers, the communication skills are essential. And a lot of work has been done to really sort of present communication skills in a very sort of straightforward manner. And I'd like to just review that with you. Context for this is that really you lead and they will follow. If your beliefs will get projected to the patient. And so the idea of the communication skills is really to create a pathway to change. And so accepting the person where they are, but helping them to frame up a pathway to where to go next. There's lots of evidence that suggests that communication is actually the key for sustained self-management behaviors, both with regard to collaborative decision-making, communication strategies. So this is very much of an evidence-based perspective. And the key really when we think about how do we communicate, and I think it's really quite straightforward, general principles that would guide you. First is be curious. So ask questions, try to minimize your statements. For instance, if you want to make a recommendation, rather than say, here's what I think you should do, you say, would you be willing to consider doing? So take a recommendation that would be a statement and make it a question, much more able to engage the patient. Empathy is critically important. Expect resistance and support the confidence of what the person can do and then find their next step. And so a way of simplifying this is in this sort of 4-step approach. And I'd really like you to reflect on it because it's actually quite easy. So when you're encountering a person, let's say who's pushing back, and so this is some of that challenge that we found. The first step: acknowledge, empathize, normalize the response that the person is engaging in, so they feel understood. Then you ask permission to work together to better understand what's going on and consider strategies for change. This is very collaborative. Then you ask the person, the child, the family, what their thoughts are on possible solutions. That's very collaborative. And then you ask permission to provide your own solutions. So your recommendations, your ability to educate, your guidance is very, very much part of this. But it's not the first step. In fact, you can see here is the fourth step. This uses a communication style that I've had a lot of success with in training, which is just really ask, listen, summarize, invite. And by the way, the hardest parts of this are the listen and the summarize. It's very easy to want to jump right into the recommendations. But if we think about this as sort of a pattern, and I like to consider it communicate, that's the ask, listen, summarize. To negotiate, and that's the invite. Because remember, the patient, the family will make their choices based on their experience outside of the clinic, not inside of the clinic. So just to reflect, think about Debbie. Debbie comes in, she's that 16-year-old who's heard something else. We understand what's going on, we reflect on it, and then we invite her to consider. And so this is where this concept of readiness can become really useful. Just imagine asking Debbie, if you were to maintain a focus just on the numbers of pounds lost and not on health behaviors, because you can control your health behavior, you can't control the number of pounds. Would that be a problem? Would it distress you if you became so focused? Are you interested? And we then sort of try to understand, where is the patient relative to our recommendation? And remember, the idea of understanding readiness is not to make people ready, but is to really identify where they are so we can support them. So in other words, what I love about a readiness assessment, and I like the traffic light model because it's just so simple: red light, stop; green light, go; yellow light, I'm pulled in two directions. And it's very easy for people to understand that. And so the idea is that then we meet them where they are, and we help them to the next step. So when they enroll in your program, think about them as being in a ready state. But then guess what? Adherence challenges are very normal, and they are really, the green light becomes yellow. And the motivational communication strategies are really a way of reducing red light outcomes. And so when it comes to promoting readiness, we have to really accept that ambivalence is normal. And so what's really the most common, and probably the state that you can be most helpful to your patients with, is the yellow light stage, when they're sort of pulled in two directions. And we know that by examining their thought process and supporting them in addressing the issues, we can help them sort of tip the balance. Very common strategy to use to do this is called decisional balance, where you just kind of spend a bit of time talking about the reasons to stay the same and the reasons to change. And so once you fully understand that, then the invitation is, can we work together to tip the balance towards staying in the program? And it's there where we see good communication skills really encourage and support a patient to continue to collaborate with the providers to achieve the goals that they're looking for. The one thing that I like to think about whenever I interact with programs that provide family-based care is, I like the metaphor. Can you juggle? Well, it turns out you juggle all the time. So working with families, you're totally dealing with multiple individuals. And so what we've had success in is conceptualizing a family in terms of this idea of where is the family regarding kind of readiness. And so you may have a green light mom, you may have a ambivalent dad, and a red light child, or any combination of those. And the juggling component is using your communication skills to try to help address those issues, not let the red light kind of interfere with the whole thing, support the green and the yellow lights to sort of consider change. So in the last couple of minutes that I have, I'd like to just make a couple of comments about communication challenges regarding obesity specific contexts. And the reason really for this is that with many chronic diseases, the diagnosis of the disease is the beginning of the journey, the beginning of self-management support. So you might diagnose someone with a disease state. With obesity, when we see people at diagnosis, it's not the beginning. They've been engaged in in addressing issues for many, many times. And so we see this very commonly. People have been trying to manage their weight. And so there's a strong, strong cultural belief system around weight. And it's best reflected by the question, to what extent is weight under behavioral control? Right? And think about goal weight and ideal weight, concepts that people use all of the time. And is weight under behavioral control, is that low? Is it moderate? Is it high? Well, the evidence is crystal clear. Weight is not strongly under behavioral control. So you cannot control your weight. And that's a really provocative statement, but true. So what is the weight loss curve? And everybody understands this. The weight loss curve is a period of weight loss. Doesn't matter whether it's behavioral, medical and behavioral, medical, surgical, behavioral, doesn't matter. Everyone has described this curve where there's this kind of plateau, and then the full curve is a slight increase. And we believe that this happens because of the neurobiological counter-regulatory response to weight loss. So weight loss is not under behavioral control. It's much more dominated by neurobiological challenges. So the basic bottom line is weight is not a behavior, and yet weight is the goal that everybody has. And so the challenge of obesity management is to nuance the goals from engaging in the health behaviors so that you can have the healthiest weight you can achieve. But that's not something that you can dial up like, I want to lose 80 kilograms, I want to lose 20 kilograms. And so the problem, of course, is that this produces this extreme issue around expectations. And the problem with expectations is as follows. My weight is my worth, and success is measured by weight loss. And this becomes problematic because what happens is that you get this, I try and I fail, I try and I fail, I try and I fail. And this produces a very powerful phenomena that's quite dangerous called learned helplessness. And so and the problem with learned helplessness is once you get into this state, it's really hard to get out of it. And so it's really important to be aware of that with regard to those particular expectations. And again, this is where acknowledge, ask permission, engage, and collaborate becomes so important. So my final slide is really just as you sort of focus in on the behavioral changes, just be mindful of the sort of general psychosocial issues. And this is an important area for us to be kind of cognizant of. How do we sort of judge how people are managing? And the individuals who are most likely to be successful are able to do two things. One is that they can understand how some of their unhealthy behavior actually serves a purpose. So if you think about emotional eating, there's a perfect example. So can we replace that function? And also as people start to adhere, the kind of key, the successful sustained adherence is associated with a positive self-image. You've incorporated those new behaviors into your sense of who you are, confidence to overcome the barriers, social support for the behaviors, and stress management. So thank you very much, and I'd be happy to take any questions. I'll just stop sharing my slide now.
Thank you, Michael, for a fantastic presentation. I'm sure there are many questions to this, and I encourage you all to put your questions into the respective Q&A tool so that at the end of our webinar, during our final Q&A session, we'll come back to that. But just before we move on, Michael, you said that we have to expect challenges, right? And communication is crucial. Communication within the family is crucial. So in order not to get tied up with this autonomy struggles, what can we tell parents in the very beginning not to get too much tied up and how to communicate with their child?
I love that question. It's probably one of the biggest challenges. And what I would encourage the team to do is really play to your skills, use your knowledge. And I think it's actually really important for us to think about the sort of the cohesive team. And so in a way, what I think you want to do, and this is so common, and you'll probably see it every single day, where the tension between the child and the family is such that you get all of these kind of buttons being pushed. I'd like you to just reflect on the fact that when your families join the program, think about it in the sense that you can become the conduit between the child and the family. So in other words, encourage the sort of communication to go back and forth. So just even in an interview, you kind of see the parents and the kids, and they'll kind of get into it in front of you. That happens really commonly. And what if you could do is just kind of put yourself between that. So you try to filter the communication, because what we want to do is kind of separate it out and see that if you kind of, you know, parent makes a comment, child responds to it. Oh, you know, mom, you always say that. I can't stand this anymore. And you kind of get this kind of really kind of strong reaction. And if you think about this is where the role of the clinic is really great. So in other words, you're sort of in the middle there. And as you sort of put yourself in the middle of that communication, what will happen is that you'll be able then to sort of, mom says something, and then before the child, then you can provide a bit of what we call corrective feedback and educate the parents. One of the most challenging things I think for parents to do is kind of is be silent and sort of allow you know, a bit of space between what you say and the reaction to it. So in a way, it's kind of like, and that's why I like to use the word sort of juggling. You're kind of balancing back and forth. But think about it in terms of that three-way communication. It's really effective at kind of slowing it down and sort of taking all those sort of hot emotional aspects out.
Thank you so much, Michael. The two of us, we will see each other at the end at our final Q&A session.
Thanks.
But for now, thank you so much. We will now move on to our second presentation by Dr. Angela Alberga. Let me introduce you to her very briefly. Her presentation has been recorded as it is in the middle of the night in Canada. She was born and raised in Montreal and completed her BSc at Concordia University in Montreal. She then completed her MSc and PhD in the School of Human Kinetics, specializing in exercise physiology at the University of Ottawa. She was awarded the Canadian Diabetes Association Doctoral Research Award for her research focusing on improving the cardiometabolic health of children and adolescents with obesity through exercise. It is through these experiences that she learned how prevalent and harmful weight-based stigma is, and has since been devoted to research, teaching, and knowledge translation efforts to reduce weight discrimination in society. Alongside her interdisciplinary research training in health promotion and disease prevention, she has over 15 years of experience working with children, youth, and adults as a camp counselor, educator, mentor, coach, instructor, personal trainer, and clinical exercise physiologist in academic and community settings across Canada. So she is really someone to listen to. And before we listen to her, I would like to show you a polling question that Angela prepared for us. So may I please ask Milena to present us with the polling question, and I will then ask you again to read it and give your answer. Dropout rates are important to know in your own setting. And this is something that Angela will be answering throughout her presentation. So Angela, thank you so much for being with us. The floor is yours.
Hello, everyone. My name is Angela Alberga, and I'd like to thank you all for being here today. And I'd also like to thank the organizing committee for inviting me to give my talk on understanding low adherence to an exercise program for adolescents living with obesity. Now, the majority of the findings that I'll be presenting here today are actually outcomes from my PhD and my postdoctoral fellowship. But now I'm actually an assistant professor at Concordia University in Montreal, Quebec, Canada. I'm an adjunct professor at McGill University in Montreal as well. So these are the 24-hour movement guidelines that are used now in Canada. And these are a really nice change from movement guidelines that were given years ago, where mostly the recommendations were focused on improving physical activity levels and decreasing sedentary behavior. But what a nice change from these 24-hour guidelines is that they really are an integration of increasing physical activity, decreasing sedentary behavior, and improving our sleep to really help benefit the health of our children and youth. So these are the guidelines that change quite a bit from before. And every year, in addition to the guidelines, there's actually a report card that's published every year from Participation and the group at the Children's Hospital of Eastern Ontario. They actually produce a report card to give Canadians a grade based on their physical activity levels in Canada. And this was the report card that was just released in 2020. And as not a surprise to many of us, but physical activity levels are still not considered very high to receive a good grade in physical activity. So when we look at some of the grades for physical activity in Canada, Canadian children and teenagers received a grade letter of D+. This year in 2020. And in 2018, the grade that was released was a D+ as well. So grades have not changed. And this is for the second consecutive time that Canadian children and youth received a grade letter of D+ for their physical activity levels, which suggests that we have quite a bit of work still to improve physical activity levels and adherence to exercise programs and interventions among children and teenagers. So speaking of adherence and exercise levels in Canadian children and youth, this report card from 2020 actually showed that 61% of children and adolescents are not actually meeting our physical activity guidelines. And 31.5% of children and adolescents have overweight or obesity. Now, the reference here that I provided from 2012 was more relevant then. I know this is many years old now, but it was more relevant in the context of the study that I'll be presenting that really tried to address some of these lower physical activity levels and the higher rates of overweight and obesity in children and teenagers in Canada. So this began the idea for the HARDY study. And the HARDY study, the acronym stands for Healthy Eating, Aerobic and Resistance Training in Youth. And what this study does was it really wanted to look at 4 different groups. So the groups of exercise, on aerobic exercise, resistance exercise, a combination of the two, or a non-exercise control group. And the purpose of this study was to actually see how these exercise groups compare to each other in terms of outcomes relating to percent body fat and body composition. And we also measured other outcomes, including fitness and mental health. So out of the HARDY study, we had 304 adolescents who participated in the trial. They were aged 14 to 18 years old and were all considered post-pubertal. They mostly had obesity, which at the time was considered having a BMI only above the 95th percentile, or if they had overweight, so a BMI between the 85th and 95th percentile, plus an additional diabetes risk factor, they were included in our study. We also asked for participants' levels of physical activity at baseline to really make sure that they were inactive prior to beginning in the trial. And this was considered to be less than 2 weekly exercise sessions of 20 minutes each. So at baseline, our participants came in, we tested them for body composition using MRI and various other measures of health and mental health. And they first started in a 1-month combined exercise run-in program. So that really was a combination of aerobic and resistance training exercises, where it was really important to measure safety and make sure that teenagers knew how to do the exercises and were maintaining good adherence. So if they actually maintained an 80% adherence rate throughout that first month, then we would randomize them into one of 4 groups. They could be randomized into the aerobic resistance combined group or the control group that had no exercise component, but all groups did have a dietary component. Then they were actually randomized into those groups to maintain that exercise group for a subsequent 5 months. And then we also measured them at 3 months, and we measured them again at 6 months for all measures related to body composition, mental and physical health. We partnered with the YMCAs, which are great community programs here in Canada, in the Ottawa area and Gatineau area, which is Ontario and Quebec provinces in Canada. And what we did was we asked our teenagers to participate in exercise. If they were trained to the aerobic training group, they were asked to participate in exercise 4 times per week at an intensity of 65 to 85% of heart rate max. They exercised on treadmills, bikes, and ellipticals, and the exercise duration ranged anywhere from 15 to 45 minutes, and it gradually progressed over time. If they were randomized to the resistance training group, they also were asked to exercise 4 times a week for a 1 to 3 sets of 15 repetitions maximum. They exercised on machines or using dumbbells, and the duration of time ranged from 20 to 45 minutes depending on the progression of the trial. So it gradually progressed from 15 minutes or 20 minutes all the way up to about 45 minutes throughout the end of the trial. And the combined exercise group literally did the combination of both. So they did end up doing a longer duration of exercise. And this ended up being anywhere from about 30 minutes to about 50 minutes to 90 minutes total. So they did exercise the combination of time between the aerobic and resistance program. So each session was longer for them. So they did a combination of both exercises on the days that they were asked to exercise. So here are our participant characteristics. We had 304 participants. We actually had 70% females who came to our trial. It wasn't designed this way to only, or get the majority of females, but this is how participants were interested in our study. The majority of our participants were Caucasian, aged about 15, 16 years old. Their weight was 98 kilograms at baseline. Their waist circumference, 97 centimeters. And their BMI was approximately 34.6 with a high percent body fat at baseline. Now here are the results in percent body fat. So if we look at the intention to treat group, this was our largest sample of including everyone who participated in the trial, regardless of attendance and regardless of adherence. We actually saw reductions in percent body fat in the aerobic group, resistance, and combined group. But what's interesting is we also ran a subsequent analysis where we only included those who had a high adherence rate. So here in the per protocol group, we actually included only the participants who maintained a high adherence of more than 70% of prescribed exercise sessions, which amounts to about 3 times per week to come to the gym to exercise for this trial. And we actually found that the combined group in the teenagers who are most adherent had the highest reductions in percent body fat by participating in the combined exercise group. We also found improvements in cardiorespiratory fitness. And if we look at the results here, we found great improvements in the aerobic group, pre and post training in the intervention group. So if we look here, VO2 peak is on the y-axis. And we measured this using treadmill graded exercise tests. And we found, interestingly, that when we only looked at participants who adhered the most to the trial, we found increases in the aerobic group and the combined group compared to the control. Whereas in the intention to treat, it was mostly just the aerobic group. For the results regarding mental health, we also found improvements in body image, mood, and self-esteem. Most of our results were actually seen in all the exercise groups. So aerobic, resistance, and combined, they all found somewhat different results in different mental health outcomes, but overall, there were improvements in different mental health markers throughout each exercise group. So we actually found that all groups improved in appearance evaluation, body area satisfaction, and self-perceived sports skills, physical conditioning, strength, and physical worth, which are really interesting findings considering that it didn't matter which exercise group they actually were in, but they did find improvements in many of these mental health markers. Now, we showed you all these improvements and all these great outcomes from our trial, but what could have been improved? What about the adherence rates, and what about the dropout rates in our trial? Well, when we look at dropout rates from our trial, we actually found that the dropout rate ranged from about 23 to 28%. And this is a considerably high number in our trial. So the aerobic group had about a 24% dropout rate, resistance about 28%, combined 23%, and even the control group had a 25% dropout. And typically, most people who work in interventions recognize the difficulty in adherence in intervention programs. So this perhaps is no surprise to anyone, but it is still quite surprising considering how many resources were put into this trial, and how all participants who actually participated in the exercise program had personal trainers. They were followed and trained personally with their trainer a couple times throughout the intervention. They had to maintain a good adherence at the beginning to maintain randomization. So there was a couple of things that were definitely taken under consideration to try to keep up adherence during our trial, but yet we still saw high dropout rates. So this led us to a big question to really understand what predicted low adherence, and why did we see these dropout rates in our children and teenagers who participated in this trial? And we want to look at, did it really have to do with their physiology? Did it really have to do with their BMI levels starting in the trial? Or was it really more psychological or psychosocial variables that influenced their participation in physical activity in our program? Well, we looked at a series of different measures. So we looked at demographic and physiological measures. We want to look at age, body weight, BMI, waist circumference, waist to hip ratio, percent body fat, resting metabolic rate, and fitness. And we also want to see if any psychological measures actually predicted adherence. So we looked at body image, mood, self-esteem, physical activity motivation, exercise self-efficacy, and self-confidence. So as you can see, we really looked at a large variety of outcome variables that could potentially predict low adherence in this trial. And interestingly, when we looked at what predicted low adherence, we actually categorized low adherence as being teenagers who attended less than 70% of these sessions. And what we did was we conducted a univariate logistic regression to predict reasons for low adherence. And what we found was here, if you take a look at this table, these are all the physiological or demographic variables that we looked at as potential predictors. And here overall, you'll see the overall sample of 228 participants, the low adherence group being 141, and the high adherence group being 87. And out of all these variables that we looked at, we found no significant differences between the low adherence and high adherence group. None of these were significant predictors in adherence in our trial. Then we actually looked at the psychological parameters, and we found that the only predictors of low adherence in our trial were appearance orientation, mood, so specifically depressed and confused mood. These were our only predictors of why teenagers had a low adherence to our exercise program. And when we talk about appearance orientation, that's essentially meaning when individuals place a lot of importance on what they look like and what their appearance is. So if anyone wants a little bit more information on this study that we did, we published this just last year in Obesity Science and Practice. And this paper just details some of the results that we found regarding predictions of low adherence. Now, it's clear that from our study, we actually found that participation in any form of exercise, be it aerobic, resistance, or combined, yields positive health benefits for teenagers living with obesity. Even though we found no changes in body weight, no changes in BMI in the overall sample, despite improvements in fitness and mental health. So those are important findings for physical activity interventions to consider. Considering we found no changes in body weight and BMI in our total sample. We also found, though, that greater adherence, so more than 3 times per week, with a greater volume of exercise, essentially doing the combined aerobic and resistance training, did actually show greater health benefits. So some of the things to discuss today are that we do know that low adherence is a big problem in exercise interventions with children and youth, and our study is not the only one to showcase these types of findings. Now, what would be important to consider in the future is actually to talk about considering the intervention design and what is actually included in the components of training the teenagers, what components are included for the design of the trial, be it what outcome measures you're using, how you're actually measuring teenagers, what the actual outcomes are, what the objectives are of the trial. And something that the International Behavioral Trials Network actually does a fantastic job at is they really look at methodology. And a slogan that is kind of important to think about is, well, maybe it's actually not a fault of your participants, but it's actually a fault of the intervention design. And that may actually be a reason for why we're not seeing the rates of adherence that we want, and we may not even see the outcomes that we want or that we envision to see from our trial, because our intervention trial may not have addressed what we should be addressing to improve adherence in children and teens. Another thing to consider is consider intervention outcomes. Oftentimes when we think about obesity research and we focus on reducing the prevalence of obesity or reducing weight and BMI, we often may miss some really other important outcomes, especially in children and teenagers who are undergoing a difficult and sensitive period in their life through growth and puberty and maturation. So I think it's especially important for us to stop focusing on body weight and BMI and really looking at other health outcomes that really actually may matter more and may actually be better for the mental health of our children and teens. So what we do know from our Hardy study is that teenagers are less likely to adhere to exercise programs if they place more importance on their appearance, and if they have more depressed or confused moods. And this might be important to consider as well, because if they're actually dropping out more or they're adhering less to an exercise program because they're placing more focus on what they look like, then why should we really be measuring outcomes just based on changes in appearance or changes in body weight and changes in BMI? And this is really something that we should consider and think about in our designs and follow-ups of trials in the future with children and teens. I think it's important to start thinking about changing the focus for exercise and how we promote and talk about exercise and physical activity in our youth. We may want to stop associating exercise with just changing appearance and just to lose weight and to change our BMI. We'll want to actually think about improvements in overall health and mental health and enjoyment, which are actually really quite important to children and teens, and to actually maintain physical activity and exercise throughout the lifespan and even into adulthood. So with that, I'd just like to thank my Hardy team. So we were a really big team from across Canada, and these are some of our funders. So at the time I was doing my PhD at the University of Ottawa in Ontario in Canada, and we partnered with the Hospital Research Institute there. We had funding from the Canadian Institutes of Health Research, which is our federal body of research and health in Canada. We also had funding from the Canadian Diabetes Association, and some of my postdoc, I also had funding from the Banting Postdoctoral Fellowship from the Government of Canada that also helped me work on some of these other outcomes from this trial. And right now, I'd also just like to talk a little bit about my lab and acknowledge that now I'm at Concordia University, where I lead a research program called MILO, which the acronym stands for the Montreal Interdisciplinary Laboratory on Obesity and Health. And these are my wonderful graduate students. Some of them have actually graduated already, but these are just wonderful students that I work with who really make research and science enjoyable and fun. And they are an amazingly productive group, which is really fun to work with. So if anyone has any questions, you can email me at my Concordia email address there. You can follow me on Twitter. And if there's any students listening or any PhDs or recent graduates interested in pursuing further research in Canada, please do let me know. I'd love to hear from you. And if you're interested in working in our lab, please let us know. We'd be happy to have you. And thank you very much for your attention. And I look forward to future discussions with all of you.
So thank you so much, Angela. Since Angela, as I mentioned, is not with us at the moment, we will discuss incoming questions related to her presentation at the final Q&A. But I'm sure that you will agree that this is fits in very well, and that this type of research is crucial. Now, our final presentation that I'm very much looking forward to will be by Professor Martin Wabitsch. Martin Wabitsch is a professor of pediatrics at the University of Ulm in Germany, and he's the head of the Division of Pediatric Endocrinology and Diabetes at the Department of Pediatrics and Adolescent Medicines at Ulm's University Hospital. His clinical research focus comprises childhood, obesity, the physiology of body weight regulation in children, leptin deficiency in humans, and rare lipodystrophy syndromes. His experimental research focus is the biology of the human adipocyte. He and his group have established in vitro models for studying the biology of the human white and brown adipocytes. Dr. Wabitsch has had the clinical and experimental training at the universities in Berlin, Free University, Ulm, Baltimore at Johns Hopkins, and Nice, Sophia Antipolis. Within an ASPE research fellowship, he performed studies on the growth hormone receptor at the Hagedorn Research Institute. Dr. Wabitsch was the president of the German Society for Pediatric Endocrinology and Diabetes from 2008 to 12, and the president of the German Obesity Society from 2012 to 2015. So thank you for being with us, Martin. The floor is yours.
Thank you, Daniel. The introduction was too long, sorry. But I really enjoying this session, and also you as a chairman have put together exciting talks. I was impressed by the presentation of Michael Vallis and of Angela Alberga, and I think this third presentation by myself, I'm trying now to put some scientific findings into clinical practice. That means I like to propose a way how to get adolescents with severe obesity into treatment. And to do so, I want to include some of our results and experiences we had in the so-called YES study, Youth with Extreme Obesity study, which we performed in Germany. And I hope that I can come to some conclusions also relating to the two presentations we have listened to right now. I also would like to start with a patient, a case report, and you may remember the patients Professor Vallis has introduced to us. I have a similar case, an adolescent girl with severe obesity, no effect of lifestyle behavior so far. She has a preliminary stage of type 2 diabetes with an impaired glucose tolerance. And she also has comorbidities, hypertension, liver steatosis. She is impaired in her physical mobility due to her severe obesity. And she has also obstructive sleep apnea syndrome. So she is really severely ill, you can say. She's depressive. She likes to be on the internet, and she has no idea what to do in her life further on. She has no apprenticeship and, of course, no partner. I say of course because this is the normal experience we have with severely obese boys and girls in the adolescence period. So I have, before I have a question to you, I want to go back to her childhood. You can see here the BMI set score during infancy and early childhood. And you can see that she has been severely obese already as a young child. And then there was a very strict educational period where the parents and the girl were seen by a psychologist and a dietitian. And they trained to change their daily dietary intake and to get more physical activity. They did that quite well. So there was a good cooperation and also adherence to the protocol of this outpatient treatment, and she lost weight. But after this period of intensive treatment, she gained weight again, as you can see here with the course of the set score of the BMI. Then later on, when she was at school, with her severe obesity, people, it was not us, but others tried to propose her another way of treatment. We have in Germany these rehabilitation centers. That means these are inpatient treatment centers where the children, the adolescents go for several weeks. And she was doing that. She was going into that inpatient treatment away from her family, and also during this way of strict control of behavior by this inpatient setting, she lost weight, not as much as she lost when she was a younger child. This is also interesting to see. And then later on, when she got home again after several weeks of inpatient treatment, she gained weight again. And I've shown you the status at the age of 15 years right now. Now, I have a question to the group listening, to the participants. I think you are experts, most of you, you are experts. Some of you, you may be new in the field. So I want to know from you, what opportunities does this young person have? And you have listened to the presentation by Professor Vallis and also by Professor Alberga. So should we tell her you should lose weight? Should she lose weight? Others, maybe I heard such answers also. She can stay like she is. It's not so bad. The health insurance company, when we ask her, at least here in our country, they will propose that she should go again once more into an inpatient rehabilitation measure. That means she should go away from home for several weeks, going into training, physical activity, reducing energy intake, and then she should go home again. There is another alternative, at least in our country, and I think also in several other countries. At this age, she could go also, she could leave her family, go into a housing group. We call that housing or living group. This is supported by the states, and there is such groups in the regions all over Germany. Should we advise her to apply for apprenticeship, to go searching for a job? Or should she go for bariatric surgery? Totally different option. So what is your answer to that question? I'm sure that there are not only one answer. Okay, so the majority comes to the conclusion that this 15-year-old girl should go for bariatric surgery. And I think those who have decided to go for that advice, they might be physicians and they might see the comorbidities of that young patient. And that's why you say she needs to lose weight, and therefore bariatric surgery is the only effective measure when you have weight as the aim of your intervention. And the other option, they are also there. So some of you also mentioned that she should lose weight. Yes, that's correct, of course. But as said right now, that might be only possible by bariatric surgery. And then the other options you may not be so familiar with in other countries. I come back to that later on, but these options have to be also kept in mind. So there is no correct answer, and I agree with the majority here that bariatric surgery should be one option we should look at. Now I'd like to continue with one important finding, and that corresponds also to what Professor Vallis mentioned. He didn't show data on that. We analyzed the literature a couple of years ago, looked on the effects of randomized controlled trials aiming at changing the behavior in children and adolescents with obesity. And we saw with this analysis that a body weight Z-score reduction, BMI Z-score reduction of 0.3 is a very good success. So this is what only a minority of participants in such programs will have at the end as result. And when they achieve this result, they will also improve their cardiovascular risk factors, for example. So this is an aim which is achieved by a minority of those participating in long-term outpatient behavioral-based treatment programs. So that's the group of persons, and 0.3 is what you would aim at, and that would be an extremely good result. And now we try to see what that means for the individual. And we did some calculations. And as you can see here, we did this calculation for an 8-year-old boy. He has a weight of 40 kilograms at the beginning of a 1-year outpatient behavioral-based treatment program. And when he is successful, when he has a good success during that program, he will lose 0.3 points in the Z-score of the BMI. He will go down from 2.4 to 2.1, and that would result in a weight gain of 3.5 kilograms. So at this point, I think all of us are facing the realistic aim we have here is that we communicate to the boy and to the family before they enter into the program. Well, when you are working with us for 1 year, your boy, you as a boy, you will gain 3.5 kilograms weight. Nobody, or at least only a minority of physicians, will be such honest and tell this to the family and to the boy. Mainly or mostly, in most cases, such programs are proposed, and the aims the children have and the families have and also the physicians have are much higher, so they are unrealistic. They are entirely unrealistic, and 3.5 kilograms weight gain would be a very good success in such a program. So at this point, I want to figure out that we have in most of our work and during our practical work still unrealistic weight aims, and we do not communicate realistic aims to the patients. And that creates at the end, it's a large part of the frustration and the problem of communication. And in that girl, so this is a girl with some other measures, some other data, but she has at the age of 15 years, 102 kilograms. And then she, if she is successful in that program, she will lose 4.8 kilograms. So she will have at the end of the program a weight of 97.2 kilograms. And this is not the aim she wanted to achieve. She wanted to lose 20 or 30 kilograms to get leaner and to get also more healthy. And that's not realistic at all for her, at least given the RCT studies we have and the data we have from when we do literature analysis. And I think that's also corresponding to our personal experiences we have in our programs. So this is one major problem. So that's why we in a group in Germany have defined that the medical and psychosocial implications of severe obesity in adolescents is a main research topic. And we are all called up and we should develop a better structured care for those individuals. And this project has been running for several years and we are still evaluating data. And I have given a long list to Milena of published work, and she will share that with you on this study. In this national multicenter study, which was coordinated here in Ulm, there have been several contributors in Germany, and these names you may know. So it has been Susanna Wiegand in Berlin with her center. It has been Thomas Reiner in Datteln, whom you know also. It has been Johannes Hebebrand, psychiatrist in Essen, and Wieland Kies in Leipzig. So these 5 centers have worked together on that project. We had several sub-projects to develop that structured care within this program. So we had project 1, sub-project 1, where we tried to identify these extremely obese adolescents in different settings, because only a small number of them directly come to our outpatient clinic. Some of them do not appear because they do have no trust, no confidence anymore in the medical system. So we tried to address, to find them also in schools, in the job centers. So we had flyers around and inviting them to the study. And then the first step was to get into a conversation with them to understand their current situation, to look at their readiness in a first step, to do some diagnostic assessments, including relevant somatic and psychiatric disorders, to find or exclude them. That was one of the first steps. And in a second step, in a second project, we started with a totally new approach. And that goes along with what we have heard from Professor Vallis. We wanted to understand their feeling, their current situation, also their experiences they had in the past in the medical system, seeing doctors, trying to lose weight. And we want to have a collaboration with them. And in this program, we have done a randomized controlled trial. So we had on the one side normal care in the institutions, and then we had an intervention studying the safety and efficacy of an innovative low-level intervention to overcome the treatment abstaining behavior and to get into a motivational communication, asking, listening, summarizing, inviting them to work together. And then in the third sub-project, we had also the option for bariatric surgery, but on a planned procedure. So we had a pre-surgical program and a post-surgical program, and we wanted to see the safety and effectiveness of weight loss surgery in these severely obese patients below the age of 18 years. So they have been still young in that study. And then, of course, we're trying to analyze the economic situation of these, or the economic effect of being severely obese, and also of the treatment approaches we have. And we started to have a longitudinal observational cohort study with all the patients recruited. Sub-project 1, I have talked about this already. This is a summary, and there are also some publications on that. So we tried at the end here to find the acceptance rates for these measurements, for doing these investigations, and also the predictors to understand which of the adolescents are collaborating finally with us, with the institution, and which part of the group is accepting the additional examinations, which finally will be the basis also for continuation of our supporting system of our help. In the second project, as mentioned now more in details, the intervention program we tried to establish and evaluate had several main goals. So the main goal was not weight loss, not at all, but it was kind of a first step in getting into contact, into a communication with the adolescents, providing comprehensive information about obesity, about weight regulation, about our brain, which regulates weight, the biological basis, about nutrition, physical activity. And we went also through recent treatment options, some of them which they have already experienced. And then we, another part was the requirement of regular medical contact with the main goal to early diagnose and therapy or treat the comorbidities. This was something we as physicians thought it's important. So we showed them, of course, it's good that we cooperate, but when you have type 2 diabetes or when you have other severe comorbidities, we also want to help you, and we try to explain this to these adolescents. And then we tried in parallel to improve their self-esteem. So we had psychologists, psychiatrists working with the adolescents together. We tried to help them to reduce their social isolation, which at least in our country at the age of 14, 15 can be really severe already. And we tried, of course, also to help them in a practical way, supporting them finding educational and occupational options, and supported them in finding apprenticeship or the opportunity to enter into a job, and also to find their way in the social group and in the society. That was this part of the sub-project, sub-project 2. In sub-project 3, I mentioned you already the pre and post program we had around bariatric surgery and follow-up visits later on. And well, these sub-projects and the data, some of them have been published, others are still analyzed, but we have learned many things already in our practical work, and the scientific findings we have, we try to put them already now into clinical practice. And what we have learned and what the way of communicating with these adolescents with severe obesity is that we really need fair dealing with these patients. And I think all of you agree with me that the obesity is not the result of a wrong behavior. The patient is not to be blamed for this condition. And that's how the patients come to us. They are always blamed by the medical care system, by the parents, by the family, and so on. You know that all. The links between biology and genetics and the living conditions must be explained to these adolescents, and the patient should be, first of all, praised for his initiative to seek help. So that opens the communication, and a relationship of trust must be established. An understanding of the current needs and requirements of the patients must be developed, first on the side of the physician. And then we have also some kind of help, I think. The new classification system for functioning, disability, and health helps us to better understand also the physical needs of the patients. I think this is something we need to work with with severe obese adolescents. And then we have to develop realistic aims which need to be defined together with the patient, with the adolescents. And these aims are not weight loss primarily, but they are treating type 2 diabetes, treating sleep obstructive apnea syndrome, and also getting into vocational training and other important things of life. Now, possible healthcare services for extremely obese adolescents and young adults. This is now a specific idea for our German situation, our country. And some of the options I show here might not be options for other countries, but I try to show you what we have developed and how we try to get them, these severely obese adolescents, get them into a collaboration with the treatment centers, the 5 treatment centers in Germany. We have 3 ways. So short-term treatments are out. They do not really help. They create frustration. We have the possibility of the first option on the left side, so that we collaborate with the young people in an outpatient setting, and that we try to help them on different levels, also to treat comorbidities. That would also include the option that they may leave the family and go into a living group where they are supervised by psychologists. They will enter into self-controlled life. We have also the option in our social care system to support the family, the individual, with many measures around life. And there are other options in our social network in Germany. We have preparation courses for apprenticeships. We have support for learning a job in specific institution where the young severely obese patients are in a group, and they are outside of the normal job system, but they can learn a job, and then they have a final examination and can enter also earning money and finding their way, and so on. There are many options in our country. I'm thankful for this. The second way in the middle would be to decide that they leave their family, either to get in a long-term outpatient setting. We have these institutions where these patients can live for 1 year with support from outside for changing also their lifestyle as good as possible. And the third way is bariatric surgery. Now let me finally go through the 3 ways very quickly. The first way is, of course, the way where we go together with the patient in an outpatient setting, not focusing on weight loss, but the patient here, of course, needs to be able to go, that he needs to have some willingness to follow up. And this is exactly what we first need to do. We need motivational communication and invite him to work together. There are some implementations which are shown here. I do not read all them. The objective here is weight stabilization, treating the comorbidities, and helping in getting into their social life and into their future without surgery here. Of course, the risks are given here. So these patients may gain weight when we are going this way, 10 to 15 kilograms a year. That might be frustrating also in this good collaboration. And there are other risks which are shown here. The second way, we have also some requirements when we want to invite the patients to leave their family for a longer time. We have here the objective of weight loss, of course, changing lifestyle, improving psychological, somatic comorbidities during that treatment. And some of these patients may go that way also for preparation for the third way, for the third option for bariatric surgery. Here we need social support, and finally, at the end of or in between and going to the end of such an intervention, we need a reintegration into the normal system in school or apprenticeship. So this is something very specific which we have here in our country. So that's a very expensive intervention, but it's an option which helps some of the patients. I show you data right now. And also here we have some risks which are shown here. Of course, this is not risk-free. We have a series of patients who have been successful in such a treatment way, this way too. I show you data from 10 patients, and you can see the BMI curves over up to 10 years. So you would estimate, you would think that they all have gone through bariatric surgery. This was not the case. They just left the family and went into a protected surrounding outside of the family, training, lifestyle, and some of them had very good success. Of course, there was a genetic basis for them. They had rather lean parents and they had a lot of support. So they didn't need bariatric surgery. And of course, most of our patients, and that's what you said as participants also, they will need bariatric surgery, but you know, as me, that this is still a critical question, if at which age we should do that, at which BMI, and how can we really assure that these patients will stay with us, that they will take their supplements later on, and that they will follow up according to the guidelines in a correct way. Also, here are some ideas about requirements, how we implement that. So we need a preparation for that measure, and we need a post-surgical long-term help for them, and also program for them. And it should be only done in specialized centers. The objective here is, of course, weight loss, but then via the weight loss also if improvement of psychiatric and somatic comorbidities, and then also, of course, by losing weight or after having lost weight, that to ensure that they are able to work and to have their position in society later on, find a partner, and so on. There are risks, a long list of risks, and you are agreeing with me that we are still not able to have a realistic benefit risk assessment for young adolescents. This is nearly impossible because we have no long-term data. And all these patients should get a genetic evaluation before we send them to the surgeon, because a few of them have also a genetic basis for their severe obesity. I don't need to mention that in this circle here. We have published on that. Also a recent publication has come out, and you will have access to this. It's an open access paper where we show that caution we have to see, to read, to check whether a genetic obesity is the reason for severe obesity before doing surgery. So I think in all of these young patients, there is a need that they are included into a registry or a clinical study to see the follow-up data on these operated patients. So these three ways we have developed in clinical care in our country, they can also be switched one to the other. They are always the three options we have. And the basis is, of course, entering into a motivational communication with the patients, collaborating with them, ask, listen, summarize, invite, as Professor Vallis has taught us. That's exactly what we try to do. And if we are doing that, we have successes, as here in this young patient. He's a happy young boy, no comorbidities. He had surgery, yes. So this is something he is dealing with, but he is happy, and he would have had this intervention earlier, not only at the age of 18 years. Thank you for your attention.
Okay, so thank you, Martin, for your presentation. I can see there's
Thank you.
to lead the Q&A. Thank you.
Thank you. Thanks very much. So we have a few minutes now where we can entertain some questions. I hope you've found these presentations useful. Perhaps we can just begin with just keeping on to there's a couple of surgery related questions. Two that would come in. One would be, what type of surgery are you doing for adolescents? That's a fairly straightforward question. Maybe we could start with that one, Dr. Wabitsch.
Our surgeons here in Germany are now always doing sleeve gastrectomy. So that's the rather new option we have, and that's done by the surgeons, and I'm convinced that this is the right way to go. In very young children, so we have 14-year-olds or even younger, we are now starting with a balloon. So there are new balloons with better material than we had before, balloons which help the adolescents and their families to get the feeling what it means later on to have a sleeve gastrectomy. You can keep that balloon for up to 12 months and then decide how to continue. When you have young patients, I would go first to a trial with a balloon and later on the sleeve gastrectomy.
Thank you. Thank you. One more question for you. Perhaps you could elaborate a little bit on the family support, individual and social aspects of your surgery intervention. This question comes from someone who's a manager of an adult services where many patients have surgery and they see quite a few patients who regain their weight. And these are usually those who don't receive educational or behavioral change supports. Can you comment on the importance of those aspects of intervention within the surgery?
We have a 3-month preparational period where we have group sessions and individual sessions with the adolescents, but also with the parents. And this is on different levels. There's a somatic level, there is a psychological level, and also we try to show them what's coming to them, how they are finally going to eat after the surgery, and how they need to increase their physical activity, as Professor Alberga has shown us. So all these contents need to be shown and discussed. And already the 3 months show us whether we are doing a good job on our side and if the adolescents show up again. So some of them, they do not show up again for the appointments. And for those adolescents, I am afraid that the surgical option is not a good option.
Excellent. Yeah, I'll just make the comment, if I may, that it's a really impressive approach that you've taken. I see the sort of social integration of your basically sort of medical intervention in the context of your country's sort of social systems. Really, really impressive to see that level of integration. I think that's a real model for us. Slight question I'll take. This one is to me, so a little bit of a shift, but the question would be around the sort of behavior change counseling. How long should the process be? You know, can we make it 20 minutes or should it be much longer? Like ask and then give days for the person to think and then have a response. So primarily, I'd like to say that the importance of a communication is for use your knowledge of your family, use the knowledge of the individual. So some people will respond immediately and you'll sort of get what I call the pace of change. And so you can see some people will work on that really fast and quick, and this may be a fairly straightforward. There may well be others though, whose pace of change is much slower. And so being just really open to that, we call it sort of this non-judgmental curiosity. So I'm gonna make a suggestion to you, and I'm going to pay attention to your reaction, and I'll just sort of observe, is it a fast or is it slow? If I'm unsure, I might say, do you need some time to think about this, or would you like to consider the options and get back to me? It's actually very important for us to be open to that, rather than think, okay, this should take 10 minutes, how come it's taking 40? And thinking, oh, something must be going wrong here. It's really more discovering what the family, the individual's pace of change is. So thank you very much for that comment. I noticed there's a couple of comments around access to Dr. Alberga's papers, and Milena will address that issue. Just mindful of time, maybe it's probably at, I guess, what time is it there? It's 6:30 a.m. my time, so I guess that makes it, is it 11:30 in your time? So do you have time for another question, Daniel, or should we be efficient with time?
I think we will have to come to a close, maybe take 2 or 3 more minutes. Can I ask you, Michael, it's my privilege to ask a direct question. You mentioned that the diagnosis of obesity is the very beginning. Can you again stress on that point?
Absolutely. I think that, thank you for that. I'd love to do that. And I'd like to really emphasize that. It's so important, and we've seen this so clearly in all 3 presentations. Weight management, obesity management, is not equal to weight loss. It's equal to improvement in health, function, and quality of life. So we have to shift away from, in Canada, in our programs, when people show up at our programs, they have 3 questions for us. Question number 1, how much weight am I going to lose? Question number 2, how much weight am I going to lose? Question number 3, how much weight am I going to lose? In our country, it is the focus. And so the diagnosis of obesity allows us to reframe this from a behavioral goal, just work hard and you'll get there, to a chronic medical condition in which we can focus in on, just like we heard from Dr. Wabitsch, how they really reframe the whole engagement around a complex medical condition where the medical outcomes are the desired outcomes. From my perspective, it's the behaviors that are the outcomes. You cannot control your weight, but you can control your behaviors. And your intensive year program is very interesting, Martin, when we look at the BMI results that you just showed us. Take these adolescents, put them in a different environment, put them in an environment for a year where you can support sustained behaviors, and then you get quite great response. So the diagnosis of obesity is critically important for framing up the expectations. And there's a paper published just last week in Clinical Obesity based on the US, over 160,000 participants, looking at whether the diagnosis of obesity was made in the electronic medical record was associated with the individuals having a greater chance of losing either 5 or 10% of body weight. So there is evidence around that. So I think it's a reframe for the patient, and then we start talking about chronic disease management, where the provider is truly supportive of helping the patient learn a new path.
So thank you so much, Michael. Thank you, Martin. Thank you, Angela. I think the bottom line is that we have to respect biology and pathophysiology maybe much more than we did in the past. We need to recognize that there is psychological predictors that we need to be aware, mood and body image. We also need to be aware of the fact that there is a treatment void in between conservative non-pharmacological treatment and bariatric surgery. And we are looking forward to another webinars, one of them being on the role of pharmacological treatment. We will discuss this in February. So it is now time to close the session. Thank you again for being with us. I would like to thank Novo Nordisk, who supported this webinar. I thank you all behind the screens for being with us. I know we are on a common quest. If there's anything we can do for you, please contact us at our office. Please have a look at our website, have a look at the e-modules that have been recently released. I'm looking forward to meeting you at the next webinar. Thank you so much. Take care.